Okay, good afternoon. Welcome to our webinar looking at the A&E delays and why did patients wait longer last winter. My name is Dr. Taj Hassan. I'm a consultant in emergency medicine and also I'm the Associate Medical Director for Urgent and Emergency Care here at Monitor. I'm joined today by a team of people, Eva Fitzgerald, Ed Kendall, and Emma Mead, all economists, and also Amy Caldwell-Nichols, who is the Program Director for the Emergency Care Improvement Program. So, we want to allow lots of time for the presentation and, most importantly, for as much interaction and questions that you might have. But before we start, just a few housekeeping points. So first of all, Eva and Ed are going to speak for about 20 minutes, and then we'll have about 20 minutes or so for questions. I really would encourage you to try and submit your questions as soon as you can, as you think of them, and so that will give us the best time out of the session. Quick point on how to ask questions. If you click on the question button, which is at the bottom of the webinar screen, you'll be able to type your question in. Please type your questions as you think of them rather than waiting till the end. We'll try and identify some common themes that come in so that people get the most value from the time available. If any technical issues arise, sound drops occur, please try refreshing your browser button, and this usually fixes it. If it's anything more complicated than that, please click Tech Support, which again is at the bottom of the screen. If you're wondering, the webinar is being recorded, which includes the audio and visuals, as well as the Q&A session, and you'll find some additional information, as well as the presentation slides and the relevant URLs, which again are available in the Resources tab. And just finally, after the session's concluded, we'd encourage you to please leave feedback by submitting the poll at the end of the webinar. So, enough of me. Without further ado, I'd like to hand over to Eva.
Thanks, Bash. I'm just going to start by giving you a bit of a context and background how our project started. So, as most of you know, the Department of Health requires that at least 95% of the patients attending an English A&E department need to be seen, treated, admitted, or discharged within 4 hours. And as we can see in the chart in the slide, A&E aggregate performance against this 4-hour standard has been falling for quite a long time now, and more or less since 2010. This performance went much worse last year, in particular in Q3 14-15, it reached the lowest level up to that point until for the more than 10 years, dropping to 88%. This was almost 5 percentage points less than the performance that we saw on the same quarter the year before. This was a national issue, so it was not something that was localized in an area or only in a particular type of trust. We saw that the national performance declined across most of the systems, with 91% of trust missing the targets for that particular period, when in the period before we saw 62% only fail the task. So that was a national problem. With that in mind, what we were asked to look is what were the drivers of this massive decline. So what happened last winter that made most of the systems fail to meet the standard? And given these factors, we identified which are the actions that we can take in the future to prevent this to happen again. So before we move on, just to clarify that our analysis looks at the A&E performance against the 4-hour standard from a national point of view. And we were looking at the decline in quarter 3, 14-15 compared to quarter 3, 13-14. The way we went around answering this question was looking at the patient flow, and we wanted to understand the patient journey throughout the urgent and emergency care pathway. So the way we did it was we talked to a lot of people, clinicians inside and outside A&E departments. We talked with researchers, with directors of operations and hospital managers, to try to understand what is this patient journey and what are the different stages that the patient goes through from the moment that they enter the A&E department until they leave. And the goal for us was to understand what are the different elements inside within this pathway that can block the patient to flow through and at the end not meeting this 4-hour standard. So from our research, we developed this simple framework that, from my point of view, is one of the best things that we produced with this report. So if you have to take any slide home, I think this one is your one, because it's super easily to replicate into any system, and it gives you a very visual picture of how the system is going on. So the way we represent is basically patients enter into the A&E department via ambulance or walking or from GP referrals. Then they go into A&E, and if they are needed, then they are admitted in the hospital, and then finally they go home or they are moved to a better place, like getting care from community and social care. So the way we think about this is looking at what happened in each stage and what is preventing patients to flow through, as I mentioned before. And when we were thinking of what elements affected the 4-hour standard, we saw that there were some elements that would be under the trust control. So there would be everything around capacity of the A&E department or of other hospital departments. But then there would be things that are outside the hospital control, which could be things around the type of demand, the number of patients coming in, the sickness, but also what's happening outside the hospital in, for example, community and social care. So with that in mind, what we did was developed a set of hypotheses that then we tested. In particular, we developed 10 high-level hypotheses, and we tested all of these throughout our project. So the first set of hypotheses, which is the one you can see now in the slides, hypotheses from 1 to 6, relate to everything that talks about the changes in demand for A&E services. So there would be everything around, excuse me about that noise, everything around the characteristics of the demand. So did we see a larger number of attendances or more admissions that year than the year before, and that affected the 4-hour standard? Or were people actually sicker last winter than the winter before, and that for that reason patients needed to be longer in the A&E departments? There are other things around maybe how the patients coming to A&E, so did they change their behavior? They came at different times, and that meant that maybe A&E departments couldn't map the demand with their capacity last year. Or we had more patients coming by ambulance, and that meant that some of the resources needed to be shifted to treat those patients. So that would be all related to the demand of A&E services. The next two hypotheses look at changes in the capacity that the A&E department has, and that would be everything related to changes in the staffing resources or everything related to non-staffing resources that can also affect patient flow. So we would be thinking here around, is there any changes in the IT system last winter that was different to the winter before, and that made that maybe departments were less effective doing their work, or there was any change in the way the diagnosis flowed through the emergency department. And the last two hypotheses link to what was going on outside of the A&E department and in the rest of the hospitals. And here we would be thinking of things like, were hospitals busier and it was more difficult for them to absorb the demand from A&E departments? Or was the relationship between the A&E department and the rest of the hospitals slightly different last winter, that it made that the patients couldn't flow easily and therefore not meeting the 4-hour standard? So that was at a high level the list of hypotheses that we tested, and the way we did that was basically we looked at national data and we explored the trends and the patterns of each of the drivers that we looked at. We looked at if that each particular driver that we explored changed in quarter 3, 14-15 in comparison to the year before. Then we developed an econometric model, which my colleague Ed is going to talk to you later on, and if there's any questions, he can answer on that. And this model was very useful for us to be able to isolate the effect of each of the elements we were trying to look against the 4-hour standard. And finally, we developed a trust survey to mainly answer all the questions that there's no data for us to use, and bring some color to the data that we were actually using. So we sent the trust survey to both FTs and non-FTs. We had a very high level of respondents, like 96%. If there's anyone in the audience that responded to the survey, thank you very much. That was very much appreciated because it helped us bring a bit of light to the analysis that we did. So now I will hand it over to my colleague Ed, which will walk you through the findings of our analysis.
Thanks very much, Ava. I'm just going to walk through the findings kind of based on the same framework that Ava's presented to you already. So our first high-level finding is that A&E departments, we think, seem to keep pace pretty well with the increase in demand for emergency care, albeit that more people were waiting longer. But that from what the data we've seen, there are some questions about how sustainable the situation is in the medium term to the long term. So breaking this down into the 2 points that face the A&E is the inflow of patients coming into them and the resources they have to treat these patients. So in terms of inflow of patients, there was a growth of around 6% in terms of A&E attendances. So A&E departments were having to deal with considerably more activity than Q3 of the previous year. When we saw the 6%, we were quite hopeful. We were really hoping that there would just be a silver bullet. We would be able to identify who the 6% of patients were, what sort of patient types they were, and then and dusted, we've worked out what's going on. Unfortunately, when we drill down into the patient profile, we see that although there are 6% more patients, they haven't really changed in terms of composition. We were looking to see if maybe the 6% more patients were related to GP referrals, or if they were older, or if there was any sort of change in the characteristics, and we couldn't find one. The patient profile was very similar between the 2 years. In particular, what we were interested to know, because this came up in a number of the discussions we were having when we started this project, was whether there was any sort of increase in the illness or the sickness level of patients attending A&E. Obviously, this is conceptually quite difficult to measure. There isn't a simplistic way to put a number to how ill someone is. We used a number of proxies. One is the Charleston Index, which measures the number of comorbidities patients have. One is triage data from Public Health England, which looks at what category of severity attendances have been triaged into, and things like age and kind of population characteristics like that. We didn't find any significant change between the 2 years, the 2 periods that we were looking at. So overall, the 6% more attendances, there doesn't seem to be any change in them. And when we look to what goes on in terms of admissions, the conversion rate, the number of patients who are converted from attendances to admissions, also goes up by about 6%. And this is important for us because another hypothesis we wanted to get a grip on was whether there was any data to support the idea that A&E doctors potentially become more risk averse. Certainly, we don't see any data to support that idea. On the other hand of this sort of equation we have is the resources that A&Es have to treat the patients. So we didn't have staff data for the entire period. We only had it up to the beginning of the period that we're looking for, up to the beginning of Q3, 14-15. But it did look as if there were more staff in A&Es, not fewer, than the previous, compared with the previous year at the same period. The staff also, in terms of the seniority, the grades of the staff that we were looking at, the skill mix, the seniority of the staff seems to have been the same. The same number of junior staff, the same number of senior staff. The other part of the resource that the A&E have to treat the patients would be things like the physical capacity. And from the trust reports in the winter sit-reps last year, it appeared that there were, if anything, more dedicated resources for A&E. There were an extra 50,000 dedicated A&E bed days. And when we ask the trusts in the survey about their capacity, closing capacity or not having enough, that sort of not having enough capacity in built space doesn't appear to be a major concern in most of these trusts. So we don't think that this is a cause of the national problem. So overall, we would conclude that although the actual A&Es were busier, they seem to be working, they seem to be putting through these attendances and dealing with them. Having said that, doing this analysis did make us think a bit, because 6% is a lot for one thing. 6% year on year is going to double in size very quickly. Although 6% is a bit of a high point compared to the long-term growth in A&E attendances, there's a question as to how sustainable that is without A&Es kind of changing quite substantially to deal with that. We were also aware when we looked into what happened to these admissions that quite a large proportion of these admissions compared with the previous year were being admitted under the A&E specialty. So what this means is they're coming as an attendant, they're admitted into hospital, but they're staying in A&E and being treated there. Although there's no definitive data on this, we're fairly sure that this is due to the increased use of things like clinical decision units and acute medical units and short stay wards, where the idea is the patient probably stays there only 4, 6 or 12 hours. So this means that staff are doing extra work, as well as looking after the attendances. They're also dealing with people once they're admitted to the A&E, through the A&E as well. Finally, we're also aware that although this project is focused on the Type 1 attendances and the Type 1 performance, there has been a big growth over the past few years in the Type 3 attendances. The main finding that we have in terms of the cause, the driver of the decline in A&E performance is to do with what happens in the rest of the hospital. So during the winter 14-15, what we observed was very high bed occupancy rates. These grew by about 2 percentage points to roughly 90% nationally. And this means there's very little flexibility for hospitals to absorb changes in demands for these beds. One point on this data is that this is actually quarterly trust average data. So when we say that there's 90% of bed occupancy is at 90%, we're actually saying that there are times when a lot of places are going to be 100%, and there are going to be wards where for a lot of the time occupancy is at 100%. And this is clearly going to have a big impact on whether A&Es can admit patients to the hospital and how easy that process is. The variable that we're looking at here, the bed occupancy rate, was highly correlated with poor performance in our econometric models. And this is the case no matter how many other variables we're throwing into these models, or how we're choosing to model, what models we're using to employ and what methods and techniques we're using. It's a very consistent and significant relationship. In particular, in our headline model, we find bed occupancy rates of greater than 90% linked to a 1 percentage point reduction in performance, and over 95%, the model estimates the performance dips by 1.6%. But for the reasons I've given above about how non-granular this data is, how there isn't as much variation in it as we would like, this is probably an underestimate. In fact, we're sure this will be an underestimate because it's measured at a different level to how we're measuring A&E performance. We did wonder as well, and we wanted to test whether there was any hint from the data that the performance on the A&E standard was being sacrificed in order for hospitals to prioritise elective work. The idea behind this was that potentially there is a belief in the system that we hear sometimes that elective work is what brings the money in and it subsidises the non-elective work. This was brought up in a couple of the meetings we had at the beginning of the project, and we wanted to be able to say something about this. What we found was that actually elective activity decreased in quarter 3, 14-15 compared with the previous year. Nationally, providers were cancelling a lot more of the urgent elective operations. The rate of cancellation was up 25%. And we conclude that there is no evidence here of prioritising elective over non-elective activity. We don't see the substitution effect. Finally, when we're looking at the elective activity and particularly the elective performance on the RTT target, we see that RTT performance and A&E performance go together. They're very highly correlated. Taking all of this information together, what we're concluding from this is that it's what goes on in the hospital and what goes on with patient flow that's really important. If the patient flow is good, this is going to mean you're going to have lower occupancy, and you're also going to do better on both your RTT and A&E performance targets. Which leads on to the next question, which is why? What's going on at the back end of the hospital, potentially, which affects the patient flow? So we think that there are problems at the back end of the hospital in securing social and community care for the patients that need discharging to social and community care. We think this for a number of reasons. First off, when we asked trusts, this was the most consistent and the main concern that many had, that there were reductions in the capacity of social and community care. We know that there were an increase in the number of detox, which are the delayed transfers of care compared to the previous quarter. And we also know that the thresholds for public funding of social care have gone up, so there's less free social care to go around. However, we don't feel confident in the data that we have to be able to pin down an actual numeric estimate of the effect that this issue has on A&E performance. Principally, this is because the main data sources are inconsistently and under-recorded. Officially, these detox account for a very small number of bed days, but external research has shown at a number of sites that actually the number of patients who could be moved out of hospital is quite high. It can be up to half. Secondly, the social and community care data that is available from the social and community care providers is quite sparse, and importantly, it's not up to date. So when we were doing this analysis at the beginning of this year, we didn't have access to this data in order to use it. And finally, there's a lot that we don't know about in community and social care. There's a lot of things for which there is no data. So although we think that there is an effect here on the A&E performance, and this effect is going its mechanism is through the rest of the hospital, we're not sure of the magnitude of this effect. And indeed, we think this is something that in the future we need to get a better idea of and get better data on. Much probably less important, but at least to me more interesting, are the reasons behind why we rejected, or maybe rejected is too strong a term, why we didn't find data to support some of the hypotheses that we initially came to. So when we developed the approach for this project, we came up with lots and lots of hypotheses, and we tried to whittle them down. Firstly, before I go into this, there are some big caveats associated with this slide. First off, we were looking at factors that affect or don't affect the national decline. So locally, any of these hypotheses could be the major impediment to good A&E performance, and probably all of these are true in some locality, but we don't think they explain the national decline. Secondly, we think these factors are important to the national decline only based on the variation in the data that we have. So the data we're using for this to tease out the relationship between this and A&E performance is based on data from about 11-12 to 14-15. Obviously, if there was variation outside of the range of the data that we have, it's hard to extrapolate from the variation that we do see and the relationships that we are able to estimate. Finally, the evidence and data underpinning our judgments on these hypotheses is quite variable in quality. To underline this, I guess, we have included a RAG rating on the right-hand side to indicate our strength of belief in the underlying data. Briefly going through these hypotheses, the first one is that nationally there was a higher number of A&E attendances, and this had a negative impact on A&E performance against the 4-hour standard. Although there was a higher number of A&E attendances, as we saw 6%, this isn't correlated with A&E performance once we account for the rate of admissions. So the admissions are what's the matter, and not the attendances which aren't admitted. I've previously spoken about the hypothesis 2 and 6 to do with sickness, with a number of proxies. We find that there is no change in this over time. We did look at the variability of attendances in terms of days of the week, weeks and hours of the day, in terms of how many people attended and how variable their attendance was, and this didn't change between the two periods. It was actually almost identical between the two quarters we were looking at. Staff data we previously touched on, there were more staff, if anything, in A&E than there were the previous year. The final two hypotheses we didn't have data for, and so we used the trust survey to get the trust idea of whether non-staff related resources or departments working with A&E were principal causes of the A&E problems. I'm going to hand over to Amy now.
All right, thank you very much, Ed. As a result of this work, we've been thinking about what are the next steps. So we've been working closely with our national partners, the Trust Development Authority, NHS England and the Department of Health. And what we've put on this slide is just some of the examples of some of the actions that we are now taking this winter to try and improve performance against the 4-hour standard. So the first of these is we have been brought together some recent publications of ours together with this report on performance against the 4-hour standard into a group of documents published on Monitor's website, which include some work that we've been doing on moving healthcare closer to home, what's the evidence that this will have a positive financial impact,
on a system, and how could it be implemented in your area. The second is around how to improve efficiency in elective care. And this is a result of some research that we've been doing on international examples. The second piece of work relates to an update to the detox guidance. So we know that we have some issues in managing the detox data from last year. So this is some refreshed guidance that has been recently sent out by NHS England, which hopefully will improve the way that data is recorded and help you in your systems understand better where there are issues in delayed transfers of care. Thirdly, we're linking in our work to the exploration of new models of care to deliver urgent and emergency care. So this is part of the Vanguard's work that's been undertaken by NHS England. And finally, what I'm going to talk a little bit more about now is the Emergency Care Improvement Programme. So this is a program that has been set up only recently, and it's a clinically led program that's designed to offer practical support to systems over this winter to try and deliver improvements in quality, safety and patient flow along urgent and emergency care pathways. We're initially focusing on helping the 28 systems that are most under pressure this winter, and we will be measuring our success against patient outcomes and experience, as well as improvements to performance against the 4-hour standard over this winter. There are opportunities to get involved in this program, both if your system's interested or if you are interested. We are looking for people to support us. There is the website and the email address up on the screen there, which will be available later on as well. If you're interested, please do drop us a line. Just to tell you a little bit more about the program and what you can expect, what the systems can expect. There are 28 systems. You can see them on the map up here. They will be receiving some hands-on support from an expanded ESIS team. So for those of you who are familiar with the Emergency Care Intensive Support team, we're growing that team, and we're adding new experts from across the rest of the system, including social care, ambulance and mental health. There are opportunities for those systems to join collaborative events and attend masterclasses. In fact, the first event was yesterday and the second event is today, where they'll have opportunities to share best practice and work through some challenges with some of their colleagues and peers in those systems. We're also providing some analytical support to help use the data that we know is out there to help identify opportunities for improvement and monitor progress in each system. So there is more opportunities to get involved in that, and to find out more about both that and the rest of the work that we've been doing. That's now up on the screen there. It's all available on our website, which is www.gov.uk/monitor, which should be easy to find. And I think we're going to wrap it up there and now give everybody an opportunity to ask some questions.
Okay, Amy, thank you very much. Hope you enjoyed the presentations. So can I remind those listening that you're now able to submit questions if you haven't done so already. Please get them in now. We've got a few in already. So perhaps, Ava, could I start with you? Tell us about just why did you restrict it to Q3? What was the reasoning behind that?
So this work was carried from January to April this year, yeah. And when we started this work, we didn't have data for Q4 yet. So we were asked to look at what the most recent drop in the standard, and that was Q3. So we used the data that was available at that point, which was restricted to until December, and we just carried on that because we thought that explaining that massive decline would be enough to understand the continuous decline that we observed in Q4. Okay, thank you. Just moving on a little, Ed, you talked about the case mix of the patients, both who attended and then were admitted, and the proportion was about the same. There was a 6% increase. Did you look at age at all as to what influence age had on attendances and admissions?
Yes, so we looked at both the impact, both the distribution, I guess, in the age profile of the attendances and admissions. and also we looked at the effect that the age of these attendances have on A&E performance. I'm just looking through my notes to make sure I get these numbers right. We did find a significant effect of an increase in the proportion of attendances of people over the age of 80. We used 20-year cut-off points, so yeah. So over the age of 80 did impact the performance on A&E. And we also used this as part of our idea as to proxies we could use for illness, because we're aware, obviously, the older people are generally, the iller they're going to be in an A&E.
Okay, thank you. Tell us a little bit about the staffing, either Ava or Ed. About this, you noted that there was I think a 4% increase in staffing, but that was across the board, or was there any more detailed data as to, because there's a sort of the processing army of people, junior doctors, nurse practitioners, but then the key issue is the senior decision makers. Was there any detailed data available on any of that?
The data we had was allow us to look at the difference in the seniority of the staff, and we looked at the ratio of junior to senior decision makers, junior to senior clinicians, and we saw that the proportion was quite similar in the quarter we looked at the year before, and in fact we saw a slightly increase in more senior doctors in the A&E department.
Okay. That's a slight paradox, isn't it? Because obviously a lot of the other data coming out suggests that continue to be a lack of senior decision makers.
I think the point there might be that what we're saying here is that there were more than the previous quarter, but we're not making a judgment as to whether that is sufficient.
Okay. So that might be an area for further exploration.
Yeah, I think so.
I think we then look at what is the ideal staffing ratio as something that we didn't touch upon, because we are not clinicians, so we don't want to work on other people's food.
Okay, no, that's great. I wonder if we could move on to some of the solutions that Amy mentioned, and it looks like a very comprehensive sort of range of strategies that we're putting forward. Amy, do you want to just expand a little on ESIP and some of the challenges that you think ESIP might face over the next few months?
Well, clearly we are just about to head into winter, and so I think one of our biggest challenges is that we need to get up and running so that we can provide adequate support to the systems that we're working with over this winter, and that's clearly a big challenge for us, and that's why we're also looking for more people to help us out with this programme, both in a substantive sense but also in the sense of anybody who is working in an organisation that they think could help provide advice or support to anyone else out in the system, whether that could take the form of visits between organisations, or hosting a webinar like this, or deliver a seminar at one of our events. Those are some of the ways in which we're hoping to mobilise some of the resources that we know are out there in the NHS. I think some of the other challenges that we'll face will be around making sure that we have all the information that we need in order to be able to help people pinpoint where the problems are in their system, and I think this analysis has helped, the analysis done in this report is going to help underpin the methodology that we will be using, but that's something else that we will be developing.
Okay, fantastic. That's great. And you mentioned also the vanguards. How does the ESIP programme link to the National Vanguard strategy?
So the scope for ESIP is going to be very much focusing on how do we deliver operational improvements to existing urgent and emergency care pathways within the systems that we're working with. What we see the Vanguard programme is doing is actually trying to map out what is the future for urgent and emergency care and how will the system become resilient over the next 5 to 10 years. So we see these programs as being quite complementary. We'd like to make sure that the systems that we're working with get on a better and more sustainable footing so that they can start thinking more strategically about the work that they will need to do over the coming years, which the Vanguard should help map out for them.
Okay, great. And a little bit, one of our audience is inquiring about the detox guidance. Can you tell us a bit about why you've put the detox guidance out and how perhaps that's going to help us?
So when we were doing the analysis, one of the challenges that we faced was that the detox data was very sparse. We were not sure about the quality of the numbers, and talking to clinicians out there and talking to other health researchers, we found out that we were not alone in that challenge. So we identified that there was a gap there, and we need more clarification on the definitions of what is detox and how to allocate each detox to the different types of detox that we have. So, because there was a lot of confusion on if the patient was waiting for social care, for community care, or for something else in the data, so we couldn't just get a grip on that. So what we did was working with NHS England to help them update the guidance and provide a bit more clarification on the definitions and what are patients waiting for. And I think the new guidance that got published a couple of weeks ago is a bit more clear on what do we mean about each type of reason for detox.
Okay, great. So all of the detox guidance, the ESID program, everything will be available on the website.
Yes.
And I think some of the questioners are asking where they can get all of this information. So that's an answer to that.
So more information is available on www.esip.nhs.uk. Our website went live yesterday. Links to relevant pieces of work and reports and more information about the programme is all available there.
Okay, fantastic. So here's a good question, which I'll open to the floor, whoever wants to take it. So one of you, or I think all of you at various stages, mentioned the impact on emergency departments and the fact that the numbers attending continue to rise, and how much can EDs continue to manage such a workload before it becomes unsustainable. Perhaps this is how long is a piece of string, but how long can emergency departments manage to cope before they become unsustainable? A question close to my heart, so I thought I'd put it out there.
So I think that is a good question, and I think that is obviously one that does occupy policymakers as well. I was just seeing Jonathan Wenger speak this morning from the Urgent Emergency Care Review team, and they do very much acknowledge that there has been increasing pressures on emergency departments, and that's part of the purposes of the Vanguard programme and the new models of care, is to try to understand, well, how can we manage the additional demands that are being placed on the NHS in the most efficient and flexible way that also delivers high quality patient care.
Can I add into that? So I think that if we can manage to ease capacity outside the departments, then we will be directly helping EDs to get through their or process their patients quicker as well, because they won't have this blockage at the end that is preventing them to send patients out and is making them miss the 4-hour standard. So I think if we focus our resources in improving patient flow and easing capacity outside the departments, then we probably are going to the right direction.
Yeah, I think we're not quite. We don't know, right? We're talking about kind of about the point I mentioned in one of the slides, that we've got the variation we have historically, and it's hard to project that and forecast that with any sort of confidence. But what we do think is that really this is an issue about the admissions that are coming through A&E rather than just the number of people who are attending. And this year it was 6% for both of these things, and I think that supports Ava's point that it's in the rest of the hospital and outside the hospital towards the back end that we need to focus the efforts.
Okay. That's great. Just one last question, perhaps. Just in terms of the conversion rates within the hospital, so we accept that there's a 6% increase of admissions into the system. Was there any sense of proportionality as to where the bigger blocks were when they were in the system from one year to the next?
Do you mean where were they being admitted to?
Yeah, where they were being admitted to, and then where the block was.
So we had a look at this on the hospital episode statistics data that we have, and the proportions going off to the different treatment specialities fluctuate over time. The big increases over the past year have been in, as I said, A&E and also general medicine. And both of these are, I think my understanding is, both these are typically associated with things like clinical decision units, short stay wards. There's more admissions going towards in these directions. There's a question as to whether they might be sent more appropriately somewhere else instead of these wards, or whether this is the correct sort of place for these people to be. But it certainly seems there's a lot more activities going on in these short stay wards. I'm not really sure. I think we need to get better data to understand if these specific patients are the ones which are causing kind of bed blocking later on in the patient pathway.
Okay, that's great. So unfortunately we've run out of time now, but many thanks again to the excellent presentations, and thank you all for listening and for contributing with your questions. As mentioned earlier, recordings of the session will be available after this session, and if I could please ask you to spare a moment, rate the session by completing the poll. That will pop up shortly on your screens, and this helps us tailor future webinars. Thank you very much for listening. Have a good day. Bye.
Thank you. Thanks.